just share and then make sure that உங்க இது வருதான்னு பாத்துங்க.
Okay sir, okay sir.
Slide share பண்ணுங்க
presentation.
Okay sir.
நீங்க லைப்ரரியில இருக்கீங்களா? லைப்ரரியில இருக்கீங்களா சார்?
இல்ல சார், வீட்ல தான் சார் இருக்கீங்க.
நீங்க வீட்ல இருக்கீங்களா? ஆர்வம்?
எஸ் சார், வீட்ல தான் சார் இருக்கேன். எஸ் சார்,
வீட்ல. நெட் ஸ்பீடு தான, வைஃபைல தான இருக்கீங்க?
எஸ் சார், எஸ் சார்.
ஆமா சார்.
மொபைல் இது இல்லல?
இல்ல சார்.
இல்ல சார்.
ஓகே. ஓகே ஃபைன்.
உங்க பாஸ் எங்க இன்னும் ஜாயின் பண்ணல? இவரு குருவானந்த் சார் இன்னும் ஒன்னும் வரல. அவரும் ரவிக்குமார் ரெண்டு பேரும் ஒரு ஃபோன் அடிச்சிருங்களா? so that we'll be able to start on time. வேற ஒண்ணும் இல்ல.
பண்ணிரோம் சார்.
ஓகேங்க சார். Palashankar sir, good evening sir.
Sir, வணக்கம்ப்பா. எல்லாருக்கும் வணக்கம்ப்பா. திரு வணக்கம். தாட்சாயணி
வணக்கம் சார்.
வணக்கம். எல்லாருக்கும் வணக்கம்.
சார், இவர் பேசினாரு சார் அடுத்த மீட்டிங்க்கு. அவரு டாக்டர் என்.கே. சுப்ரமணியா ஒத்துக்கிட்டாராம்.
ஆமா ஆமா, அதனால நீங்க அடுத்து ரெடி பண்ணிருங்க. ஃளையர் ரெடி
பண்ணலாம் சார். மண்டே ரெடி பண்ணிடலாம். மண்டே ரெடி பண்ணி போட்டுருவோம்.
கிளினிக்கோ பெத்தாலஜிக்கல் கான்ஃபரன்ஸ்னு போட்டு
சரிங்க
போட்டலாம். ரேடியாலஜிஸ்டும் பெத்தாலஜிஸ்டும் அவங்க அவரு
ஆமா சார். இது கண்ணன்
ரேடியாலஜிஸ்ட் அண்ட் பெத்தாலஜிஸ்ட் அண்ட் அவ்வளவுதான். கன்சல்டன்ட் அவ்வளவுதான் நினைக்கிறேன். பல்மாலஜிஸ்ட், பெத்தாலஜிஸ்ட், ரேடியாலஜிஸ்ட் அவ்வளவுதான் முடிஞ்சு. மேபி அந்த பிரசன்டார் வேணா யாரும் வேணா அந்த கேட்டு வேணா அதை சேர்த்துக்க. அந்த ஒரு பிரசன்டார், மற்றபடி மாடரேட்டர் வந்து அஸ்வத்னு போட்டுக்கலாம். அவ்வளவுதான். சார் நாராயணன் சார் வணக்கம் சார். நாராயணன் சார் வணக்கம். நான் பிடிக்கும்னு நினைச்சிருந்தேன். நீங்க வந்திருக்கீங்க உள்ள. உங்களை வர வீசி பிடிக்கிறதுக்கு ரொம்ப ட்ரை பண்ணேன், முடியல சார் என்னால. நானும் மல்டிபிள் அக்கேஷன்ஸ் ஐ ட்ரை டு ஃபார் யுவர் டீச்சிங் செஷன் ஆர் அதர், பட் somehow or other I was unlucky all these days. இந்த ஒட்டே ஏதோ சிக்கிட்டீங்க.
ஸ்டார்ட் பண்ணிடலாமா சார்?
ஓஎஸ்.
இவர் டாக்டர் ரவிக்குமார் ஜாயின் பண்ணிட்டாருங்களா?
ஜாயின் பண்ணிடுறேன்னாரு, ஜாயின் பண்ணிட்டு இருக்காரு.
ஜாயின் பண்ண உடனே சொல்லுங்க, நம்ம ஸ்டார்ட் பண்ணிடலாம்.
முருகானந்தம் பண்ணிட்டாருன்னா ரைட்.
அவ்வளவுதான்.
ரவிக்குமார்
சாரி சார், நான் டிரைவ் பண்ணிட்டு இருக்கேன் சார், அதான் கொஞ்சம் இது வேற ஒண்ணும் இல்ல சார்.
ஒண்ணும் இல்ல டென்ஷன் ஆகாம மெல்ல டிரைவ் பண்ணு.
முருகானந்தம் சார் ஜாயின் பண்றேன்.
Happy evening. This is Dr. Ravi, pediatric intensivist from Renal.
Hello, good evening, sir.
Happy evening, Thirumogan sir.
Good evening, sir.
Happy evening, ma.
Ravi Kumar sir, good evening. I am Dr. Balasankar, President IAP.
Happy evening, sir.
Good evening, sir. நான் அந்த ஒரு 5 நிமிஷத்துல கீழே வந்துடுறேன்.
முருகானந்தம் சார் ஏதோ சின்ன இஷ்யூன்னு நினைக்கிறேன். 2 minutes போட்டுருக்காரு.
Sir, shall we start, sir?
Start, sir.
Good evening, everyone. It gives me great pleasure to be on this occasion of the 107th edition of our postgraduate clinics. This week, we have a unique perspective in the emergency pediatrics. I call Dr. Dakshani, Treasurer, to start the program with the pediatrician's prayer. Over to Dr.
குழந்தை மருத்துவனின் இறைஞ்சுதல் எங்களுக்கு முழுமையான குணமளிக்கும் திறனை தாரும். நோயரின் துன்பம் தீர்க்கும் திறன் நமக்கு வழங்கப்பட்டது. எப்படிப்பட்ட சிறப்புரிமை என்பதை பணிவுடன் நாம் உணர்வோமாக. எல்லா குழந்தைகளுக்கும் அவர் தம் குடும்பத்தினருக்கும் அவர்களின் சமுதாய படிநிலை மற்றும் சாதி மத பிரிவுகளை பாராமல் நலம், கற்றல், அன்பு, அமைதி ஆகியவற்றின் தூதுவர்களாக என்றும் இருப்போமாக. நம்மால் முடிந்தனவற்றை மாற்றவும் நல்லனவற்றை உள்வாங்கவும் மாற்ற முடியாதனவற்றை காரணத்துடன் ஏற்றுக்கொள்ளும் போதுமான மெய்யறிவும் புரிதலும் எங்களுக்கு வழங்குக. உங்களது வாழ்த்துக்களையும் அருளையும் கருணையும் எல்லா சூழல்களிலும் நேரங்களிலும் அனைத்து மக்களிடையே கொடுத்து அருளுங்கள். தேங்க்யூ.
Thank you. I now request our President, Dr. Balasankar sir, to start the inaugurate the program.
Very good evening to every one of you. It's a real great pleasure for me to do something on the academic sector, continue to do the good work started by my previous presidents. And today is supposed to be the 107th PG teaching program on through net. And it's very, very heartening to see this. And really, actually, what I can say, PGs were earlier were students of one institution only, and they will be learning from that professor, that department, that place. Now, because of this newer technologies and all, now every teacher has become a teacher for every student anywhere in the world. So it is the magic of science, actually, which has revolutionized the teaching. And we are fortunate enough to listen to so many doyens in the field of pediatrics through this modality, that is Zoom. And today we have got a very good, probably it's going to be a very good discussion on emergency cases, that is emergency pediatric cases, acute cases in pediatrics, ICU cases, which today the two distinguished resource persons are there. One is Dr. Narayanan, Professor Jipmer Pondicherry. It's a very distinguished personality known for his in-depth subject in intensive care. And Dr. Ravi Kumar, an intensivist from Renal Hospital. I hope, and Dr. Muruganathan is a mentor, and the students Mirula and Armuham are, I hope they are all ready with cases, short cases in intensive care. And I hope this evening is going to give lot of new information in managing the acute sick children in pediatrics. Thank you very much for the opportunity. I wish best wishes for the presenters and the mentors and the teachers. Thank you very much. Thank you.
Thank you very much, sir, for those nice words. I now request Dr. Murugesa Lakshmanan, our academic coordinator, to take over the session. Over to Dr. Murugesa Lakshmanan.
I think this is the first time we are conducting case presentation in an emergency case, I think. Abdizana sir, very emergency case presentation.
This is the first time actually.
Emergency.
This is something very unique.
Emergency this is the first time. Yes, you are right.
So
exactly.
we are trying
That's
something
what
new.
I'm saying. We are able to listen to everybody through this modality.
And also we have got very good faculty. The SAR சொன்ன மாதிரி we have got very two good faculties with us. So I think all the postgraduates get benefited by this. Right? So over to our moderator Muruganathan sir to introduce our postgraduates and start.
Good evening all, sir. First of all, I thank IAP TNSC for giving me this opportunity for moderating this session. Thank you, Balasankar sir, and Thimuran sir, Dakshani ma'am, and Murugesan sir. And I will introduce my PG's Armugam, who is going to present two cases. One is CVS and CNS. And Dr. Mirdula, he is going to present on respiratory case and GA case. So, shall we start, sir?
Yes.
So, over to Dr. Mirdula.
Yes, sir.
Please start.
Yes, sir. Good evening to all the great teachers in the forum. The first case I'll be presenting is about a 2-month-old female child who was brought by her parents with complaints of fever for 1 day, complaints of incessant cry for 1 day, and complaints of 1 episode of paroxysmal movements lasting for about 20 to 30 seconds, 1 hour before her hospital visit. The history of fever for 1 day, which was low-grade, intermittent, and relieved with medications. The infant also had persistent irritable cry during the interfebrile period. A history of 1 episode of paroxysmal movements in the form of uprolling of eyes and tonic posturing of all 4 limbs, lasting for about 20 to 30 seconds, associated with loss of consciousness for about 5 minutes. There was no history of refusal of feeds post the event, no history of discharge, no history of runny nose, cough, or breathing difficulty, no history of loose stools or vomiting, no history of prior trauma, no history of reduced urine output, no history of rash or bleeding manifestations. The child had no past medical or surgical history that was significant. Coming to the birth history, she was born late preterm at 37 weeks of gestational age and delivered via LSCS. The indication was due to oligohydramnios. Her birth weight was about 2.5 kg and the baby cried immediately after birth. There were no significant perinatal history. Immunization history, she has been immunized up to 45 days of life and there was no adverse effects following immunization. Family history, she's the firstborn from a non-consanguineous marriage and there's no history of seizure disorder in the family or no history of cough, cold in the family members. Development. So,
sorry, continue, ma'am. Continue, please.
Yes, sir. Yes. Developmental history, she has attained a partial head control and she has got a social smile and cooing is present. Diet history, she's been exclusively breastfed and she takes about 8 to 10 feeds per day and she feeds for a period of 15 minutes for every feed. Summary. So, a 2-month-old female child, firstborn of non-consanguineous marriage with an uneventful perinatal history was brought by her parents with complaints of fever for 1 day, incessant cry for 1 day, and 1 episode of generalized tonic clonic seizures before 1 hour of the hospital visit. So a probable diagnosis of acute onset meningitis, which is of infective etiology, is suspected. Moving on to the assessment. When we received the child at the EMD, the airway was clear. Her respiratory rate was about 40 per minute, and she was maintaining saturation under room air. Bilateral air entry was present, and there was no distress. Her heart rate was about 140 per minute. Her pulse volume was good, and her perfusion was good. Her urine output was also adequate. And she was alert. Her tone and activity were normal. Bilaterally, the pupils were reactive to light, and her blood glucose level was 95 milligram per deciliter. The temperature recorded at the EMD was 100 degrees Fahrenheit, and there were no rash or bleeding manifestations. Head-to-toe examination, the child had no pallor, itches, or cyanosis. There was no rash or bleeding manifestations. There were no obvious neurocutaneous markers. The head was normal in shape, and the AF was depressed. There was no widening of sutures. Her head circumference was 38.5 centimeter, which was appropriate for her age. Ear, nose, throat examination and spine examination was normal. Coming to the CNS examination, the child was alert, feeding well, and responded to environmental stimuli such as visual, auditory, and pain stimuli. Coming to the cranial nerves, the second nerve, bilaterally, pupils were reactive to light. And for the third, fourth, and sixth nerve at rest, there was no obvious deviation of eyeball noted. For the fifth nerve, sucking reflex was present. The baby was able to feel the sensations over face, and corneal reflex was present. For the seventh nerve, sucking was present. There was no notable asymmetry of the face, and corneal reflex was present. For the eighth nerve, startling response to sound was present. For the 9th, 10th, and 12th nerve, suck-swallow coordination was present. And for the 11th nerve, when the head was turned to one side, taut sternocleidomastoid muscle was seen on the other side. Coming to the motor system examination, the bulk was bilaterally symmetrical, and both the active tone and passive tone for both trunk and extremities were normal. The baby was able to move all the limbs in all directions, and deep tendon reflexes were editable, 2+ in all the 4 limbs. Superficial reflexes, corneal reflex was elicited, and bilateral plantar, there was a withdrawal response. Sensory system examination, the baby was able to perceive touch and pain sensation. Cerebellar signs, there was no hypotonia or nystagmus. Spine and cranium examination was normal, and there was no neck rigidity observed. Other systemic examination, respiratory system, bilateral air entry was present, and normal vesicular breath sounds were heard. Cardiovascular system, there was no murmurs, and upper abdomen, it was soft. There was no palpable organomegaly. From this history, a probable clinical impression of meningitis with probable infective etiology has been made.
Can we
Shall I move on with the investigation, sir?
Okay, yes. So what are the possible organisms you are looking at in your mind?
Sir, from the bacterial group, it could be Streptococcus pneumoniae, sir. H influenza, it's the incidence has come down now with the vaccination. The child has received 1 dose of vaccine. Or it could be viral, sir, enterovirus.
Okay. And the other question, did you comment about the AF, anterior frontal?
Yes, sir, the AF was depressed, sir.
Depressed, it's not bulged, and it's pulsatile.
No, sir. No, sir.
Continue.
Okay. Can I ask some? Hello? Hello? Can you hear me?
Yes, sir. Yes, sir. Good evening, sir.
Yeah, Ravi, can I ask a question? Hello?
Yes, doctor.
Yeah. So, so this is, since we are considering as trying to talk about this as an emergency case. So a 2-month-old child like this comes to emergency with history of seizure. So one of the initial things we are worried about is stabilizing the child. So, okay. So how do you know that this child is not in status epilepticus? How do you identify a child in status epilepticus?
So if the seizure, if there is ongoing seizure activity for more than 5 minutes, or if the child has not regained consciousness between two episodes of seizures, if there is ongoing tachycardia, and if the child is also having desaturation along.
Okay, so this child admission was sensorium was normal and there was no seizures, correct?
Yes, sir. When we received her at the EMD, her sensorium was not.
Yeah. So the emergency asked us to see the child to rule out all the life-threatening complications which this child can face. One is, of course, sensitive seizure is at its status. Second thing is the child is hemodynamically, and respiratory-wise stable, which your vitals have shown that they're stable. What are the other issue which we are worried about this child? Other complications which can actually be life-threatening in this child at the first few hours.
Aspiration, sir.
Sorry?
Aspiration, sir. Risk of aspiration.
But you said sensorium is normal, no? So
yes, sir.
Yeah. So what is the a child like this, the seizures, suspected infection, or the other dangerous thing which can actually be life-threatening at the first few hours? Is raised ICP, correct? Raised intracranial tension.
Yes.
So how do you diagnose that? So how do you know that this child doesn't have raised ICP? What are the points? Dr. Ravi has already mentioned one.
AF was depressed, sir. There was no widening of suture, sir. And there was no hypertension, bradycardia.
That's a very late sign. Hypertension, bradycardia is usually a very late sign. So what is the most sensitive sign? What is the most reliable sign in this child which makes us strongly believe that there is no ICP, other than, of course, the AF is flat, but what else? Sensorium is normal, no? So you said child is alert and active.
Yes.
Okay. So acute change in sensorium is one of the most sensitive sign for a raised ICP. So some child is absolutely alert and interactive with no change in sensorium. There is no acute raised in ICP. Sometimes they can have chronic ICP, they can have normal sensorium. So this child has normal sensorium, so that means there's no acute raised in ICP, and there are no active seizures at presentation, or there is no and child is alert. So all the immediate worries are over. Okay.
Yes, sir.
So your clinical impression, I agree. Fever with seizures, the 2-month-old child, which first possibility will be an infection. The first possibility could be anything. Viral, bacterial, we have to look at it. Okay, fine. Yeah.
Yes, sir.
You can go on. Yeah.
Yes, sir. Yes, sir. So a complete blood count was done, which showed leukocytosis with equal distribution. There was 16,000 counts of white blood cells with 47% each of neutrophils and lymphocytes. MRI drain done showed a normal study. CSF analysis showed 580 cells, which was lymphocytic, 30% lymphocytes, and macrophages were found to be around 64%. Biochemical analysis showed a protein count of 58.2 milligram per deciliter with a glucose level of 49.2, which was more than 50% of the blood glucose level at that point of time. And CSF PCR study was also done, which showed enteroviral positivity. So management, we started the child on empirical antibiotics, ceftriaxone and vancomycin. And after we got the PCR report on day 2, we stopped vancomycin. The child also received anti-epileptic drugs for 1 week, and she was on antipyretics and other supportive measures. The child had no further seizure episodes throughout the hospital stay, and there were no other focal neurological deficits. Fever spikes spaced out on day 3, and she was discharged on day 5.
Yeah. Can you go back to the slides whether you mentioned the investigations?
Yes, sir.
No? Yeah.
Yes, sir.
So what are the important investigations, point of care testing which we'll do in this child at admission? Suppose you are there in emergency, this child comes, what are the point of care tests we'll do? Yeah, I agree. CBC has to be sent. Somebody comes with seizure, no? What else we should do? Anything coming with seizure for the emergency?
Yes, sir. To look for any electrolyte abnormalities, blood glucose and serum electrolytes.
Yeah, has to be done. Okay, in this child, since child is alert, it may not be, it's not so obvious, but you should definitely do it. Okay, child you should always do a point of care test, calculate blood glucose, and you have to send this for electrolytes. It's very important in the emergency. Okay. Sorry. So
Yes, sir.
other question I want to ask is, you said you done an MRI. So
Yes, sir.
what is the indication for MRI in a child with it's presenting a 2-month-old child with an acute onset fever and seizures? So your diagnosis, you said, is acute intracranial infection, no? So
Yes, sir.
with the professional diagnosis of infection, will you do MRI first or will you do something else first?
Sir, neurosonogram can also be done first, sir.
No. My question is, can an infection be diagnosed by imaging?
No, sir.
Yeah. So when you have, we should always investigate for the first suspicion we have. First diagnosis infection.
Yes,
And
yes.
what is the role of? Okay, or I'll put it in a different manner. What is the role of CNS imaging in this child? A child of this kind of presentation. What is his role? What are we looking for when you do? See, whenever we do an investigation, we should have a rationale. Why exactly we are doing it? We should have an answer to that question. What am I looking for? So why did you do an imaging for this child? What is the rationale? What are you looking for?
So in bacterial meningitis, to look for exudates and ventriculitis.
Will it happen in one day?
No,
And
sir.
is your treatment going to change? And what exudate will be there in bacterial meningitis? Mostly we don't
Yes.
find, that TB meningitis you may get a basal exudate, but bacterial meningitis, what exudate you will get it, which is visible with CT.
Okay.
Yes, sir.
Dr. Mridula, first of all, I was very happy and very surprised to get an MRI brain as a first imaging. And as sir asked, the purpose of imaging is not to identify infection, right? What was the key feature you wanted to do with the imaging before you did a LP?
So to rule out intracranial hypertension.
Yeah, basically you want to see whether there's any mass effect, any raised ICP signs. And this child is 2 months old, no, Mridula. What is your thought process? What is the other thing which you have to think in this child?
So for cause
Remember,
for seizures,
any intracranial hemorrhages, sir?
Yeah, that's
because
very
the child
important.
is preterm.
Yeah, this child is just 2 months. Intracranial hemorrhage is one of the commonest reason in less than 3 months to have a seizure. So you want to see whether there's any bleed. Before you put anything into the LP, you have to do that.
Yes, sir.
So these are your thought process about the imaging when you do. And
usually we don't need an MRI for that. Okay?
Yes. Ultrasound or CT is what is the advantage of CT over MRI, Dr. Mithila? Advantage and disadvantage.
Sir, MRI, you get to see the soft tissue with high resolution, sir. CT, bleeds can be seen.
Yeah, you're partly right. Yes, bleed can be well seen in CT, but remember the duration you need for a CT is very less than an MRI. You need a sedation. It's not easy for an MRI for 40 minutes. That's the, but the downside of CT is radiation. And you will not be able to see the posterior aspects of the brain well, tentorial and all good in an CT. But MRI needs sedation. It needs more time. And especially somebody who has a seizure and you want to do an MRI. But that's something which is difficult at sometimes to do.
Yes, sir.
Okay.
So, please carry on.
Yes, sir. So, and then about this CSF analysis, you were saying about, consider this to be it's more of a lymphocyte predominance in low neutrophil, and sugars are 58. And sugars are actually, the ratio is less than 0.6.
Yes, sir.
In an infant, you have to take not 0.4, you have to take 0.6 as a ratio.
Yes, sir.
So possibility is one viral or even a partially treated meningitis also should be thought, but you have done a CSF PCR and you have looked for enterovirus.
Yes, sir.
Okay. When you looked into because if somebody has given antibiotic 24 hours, it's quite common when you are in a teaching institute or in a bigger hospital, They may have come
Yes, sir.
after giving some antibiotics. Even 24 hours of antibiotics enough to change everything what you're seeing there.
Yes, sir.
And the antibiotics you kept, did you think in your mind about late onset sepsis of newborn?
Sir, the child had an
Why
was
I'm asking
alert.
this question, as per the definition, up to 90 days, that has to be kept in mind. And when you do that in your mind, the antibiotic which you are giving, you need to cover Listeria. That's the reason I'm asking you this question.
Yes, sir.
Okay.
Yeah.
Yes, sir.
Okay. After Narayan, anything more if you want on this case?
Yeah, I agree with what you discussed. If it is usually what we usually do in this kind of children is, if presentation is like the child sensorium is completely normal, AF is flat, and then we usually not even do a CT most of the time. Just for first diagnosis, we may do a neurosonogram at the most, and then we do an LP. If LP is not suggestive only, then we will, then we do more imaging or more other investigation. So this LP is classically, the examination is classically suggestive of an acute infection. Correct. And I agree with the points he said. With such high cells, 580 cells, and this glucose, antibodies has to be definitely given. We can, our first diagnosis is always bacterial meningitis.
Yes,
And
sir.
till the CSF PCR report you get. Another point which he has already mentioned about the antibiotics, I agree with him that first, even though we say 2 months, but first 3 months is the time maybe cover for all the perinatal, like gram-negative meningitis also will consider. So,
Yes, sir.
so if your area has a lot of, if you get a lot of, ceftriaxone may not be sufficient sometimes if you have a lot of VSBLs all in your area. So we may have to think of maybe a meropenem or something initially and then downgrade later, depending on the what is the usual sensitivity pattern in your area where you work. Yeah, beyond 3 months usually we
Narayan,
only
sir?
ceftriaxone. Yeah.
Narayan, sir?
Yes, I can hear you. Yeah, I can hear you. Hello?
Sir, I have one doubt, sir. At what
Yeah, please.
point of time can we think of any IEM causing, since the child is having 1-day fever with sudden onset of seizures? Because any IEM usually present in case of decompensating phase. Could it be possibility of think of IEM in the 2-month-old infant?
Yeah. So IEM is classically, clinically, what we think of is when we have unexplained, seizures or unexplained sudden worsening. Here it is all explained. We have very good explanation for his seizures and the fever in form of the CSF analysis. So no. So this kind of CSF, if you, we are not going to think of IEM. Suppose the CSF is completely normal and child gets repeated seizures again, sensorium goes down, and you do a CD, nothing is there. That is time. So IAP is something where we cannot explain very easily. So this is, so in this child there is no question of thinking of IAP unless there is Okay. Now one more question I can ask: what are the usual complications you expect in this child? Suppose it was bacterial meningitis. This child had a very good improvement. So it did very well. Suppose the child's fever does not come down after say 4 to 5 days and he continues to have some seizures even after that. What will you think of? You understood the question? Huh? I mean, suppose CSF PCR is negative and culture also is negative. Suppose or culture grew even say hemophilus or some and you give sensitive antibiotics for say 5 days or still child is showing fever and child is not improving. So what will you think of?
So, other complications like abscess formation.
Yeah, first thing is, of course, we should think about we are giving the correct dose and all the we're covering the organism properly. Then, of course, we should think of complications like what?
Yes,
what are the
sir.
common complications which can develop in the after bacterial meningitis during the treatment? They can develop subdural effusions. They can develop brain abscess. Then fever is continuing, means they may have other focuses. For infants, they can have some other disseminated focus. They may have an arthritis or something which may need drainage, especially with hemophilus and pneumonia. Further infection could be there, which we haven't identified. All right. Okay,
yes,
fine.
sir.
The presenter was right. The presentation. Okay. So we go to the next case. It's over, no? Anything more?
Yes, sir. Yes, sir. Yes, sir.
Yeah. So the learning point in this case is any child coming with seizures, our initial first priority in the emergency is to identify life-threatening problems. Common life-threatening problems are where they are in status, where they have any raised ICP, where they have any hemodynamic compromise, because they can easily go into systemic sepsis, this age group. Once you these things are ruled out, then we go for the etiological diagnosis. In a child with suspected CNS infection, the most important investigation is always CSF examination. Okay, there are only very few contraindications for that. Which is none of the, in my opinion, there are no contraindications in this child clinically to do a lumbar puncture. Child has no feature of raised ICP, child is stable. So imaging also is plus minus. In my hospital, I will not do imaging for this child before doing CSF because clinically I'm reasonably sure that there is no other issues with this child. Okay, I agree. It is a possibility. If you suspect that, you can always do an ultrasound to start with, and then later do a plain CT. That's what we will do. MRI is a little bit of it may not be needed in this child. Of course, it gives information, but the information is not much use for this child. Management, of course, is straight away. You should give antibiotics till you rule out a bacterial meningitis, which we usually give after around 2 to 3 days. Yeah. And antibodies should be based on your local flora and depending on the age of the child and the immunization status. Is also important. Okay, thank you.
Sir. Yes, thank you, sir. This is the next case presentation. It's about a 3-month-old female child who is the firstborn of non-consanguineous marriage, was brought with complaints of poor weight gain since birth, complaints of difficulty in feeding for past 4 weeks, complaints of cough for past 2 weeks, and complaints of fast breathing for past 2 weeks. Presenting illness, the mother noticed the baby to have poor weight gain since birth. Her birth weight was about 3 kg and she weighed 3.3 kg at the present admission. Complaints of difficulty in feeding in the form of sucrose cycle associated with increased perspiration. Complaints of cough for the past 2 weeks, acute in onset wet cough aggravated post-feeding. Complaints of fast breathing for past 2 weeks associated with chest indrawing and worsening while feeding. There was also a history of thick nasal discharge, history of noisy breathing for past 4 days, history of no history of fever, no history of frequent regurgitation of feeds, no history of bluish discoloration of lips or fingers, no history of reduced urine output, no history of swelling of abdomen, no history of seizures or lethargy. Past history, she had 2 respiratory tract infections last month requiring hospitalizations. Both the admissions, she needed oxygen support and IV medications. Antenatal history, there were no maternal comorbidities, no history of maternal fever with rash, no history of maternal drug intake other than iron and folic acid. Perinatal history, she was born term by a normal vaginal delivery. Her birth weight was 3 kg. The baby cried immediately after birth and there was no significant perinatal history. Immunization history, she has been immunized up to 45 days of life and there was no adverse events following immunization. She is the firstborn of non-consanguineous marriage and there's no history of heart diseases in the family. Developmental history, she has attained partial head control. She has got a social smile. Cooing is present and she is able to fix and follow light. Diet history, she's being exclusively breastfed. Summary, this is a 3-month-old female child, firstborn of non-consanguineous marriage with uneventful perinatal period and history of 2 prior hospitalizations for respiratory tract infection requiring oxygen therapy and IV medications in both the admissions. Now she was brought with complaints of poor weight gain, difficulty in feeding for 4 weeks, and complaints of cough and fast breathing for 2 weeks, and this was not associated with any cyanotic spells. So a probable diagnosis of lower respiratory tract infection with an underlying cardiac pathology, a cyanotic heart disease is made. Moving to the initial assessment at the EMD, the airway was clear. Coming to the respiratory part, there was nasal flaring, bilateral intercostal retractions were present. She was tachypneic. She had a respiratory rate of about 70 per minute, and the room air saturation was 86%. And with 2 liter O2 via nasal thromb, it improved to 92%. Bilateral air entry was present and bilateral wheeze was present. This indicates the presence of respiratory distress. And her heart rate was about 130 per minute. The pulse volume was good. All peripheral pulses were felt and they were regular. There was no radial or radiofemoral delay. Perfusion was adequate. Her BP was 80/55 millimeters of mercury. On auscultation, there was a pansystolic murmur heard over the left lower sternal border and a loud P2. Her urine output had been adequate. The baby was awake, alert, but not playful. The tone and activity was normal. Bilateral pupils were equally reactive to light, and her sugar was 88 milligram per deciliter. Temperature noted at EMD was 99 degree Fahrenheit, and there were no rash. Head-to-toe examination. There was no pallor, icterus, cyanosis, or dependent edema. Her head was normal in shape, and her anterior fontanelle was 2 × 2 centimeter. Her posterior fontanelle was closed. Her head circumference was about 39 centimeter. There was nasal flaring present. Ear and oral cavity examination was normal. Spine and extremities were normal, and there was no dysmorphism noted. Coming to systemic examination, serious examination, inspection showed a normal chest wall shape. Strata appeared to be in midline. There was no precordial pulse. Visible pulsations were seen over the precordium. There were no engorged veins, no scars or cyanosis. Palpation showed a trachea to be in midline. The apical impulse was felt at the fifth intercostal space, later to mid-clavicular line. It was hyperdynamic in nature. There was also a palpable P2 and a palpable thrill over the left lower sternal border. There was no parasternal heat. On auscultation, there was a loud P2 and a grade 4 pansystolic murmur heard over the left lower sternal border, which was non-radiating in character. Other systems examination, respiratory system examination showed bilateral air entry and the presence of bilateral wheeze. Periodontal, the liver was palpable 3 centimeter below the right costal margin with a span of about 9 centimeter. And CNS examination showed no focal deficits. With the above picture, a provisional diagnosis of acyanotic congenital heart disease with increased pulmonary blood flow, most likely ventricular septal defect, with pulmonary hypertension in congestive heart failure with failure to thrive and associated bronchiolitis has been made.
Yeah, shall we stop here? No,
Yes, sir.
stop here. Yeah, just go back one slide. Yeah.
Yes, sir.
Yeah. So I think first question from our side is okay. Most of the things are explanatory. You know, your child is going acyanotic congenital heart disease. I agree because why you're saying is acyanotic congenital heart disease?
Sir, the child had no history of cyanotic spells, and
but the SpO2 your record is only 93, no?
Yes, sir. But that was because of left to right shunt leading to more pulmonary flow and the dyspnea, sir.
Dyspnea will not produce cyanosis. No, cyanosis there should be right to left, correct?
Yes, sir.
Okay, fine. Yeah. So can you completely rule out this is a cyanotic congenital heart disease? So how does a cyanotic congenital heart disease pulmonary blood flow present? Will they have marked cyanosis or will they have mild cyanosis?
So mild cyanosis.
Yeah, it can be missed. Okay, cyanotic heart disease increased pulmonary blood flow like a TGA and all that. No.
Yes, sir.
Increased pulmonary blood flow will have a very mild cyanosis. Clinically, it may not be obvious. They present exactly like a VSD or large VSD. The presentation looks like, but only when you check you find that it is low. Okay, so in this child is a confounding factor. This child has got a respiratory infection. So we don't know the low saturation is because unless you had a saturation recorded when child not before a respiratory infection, we cannot completely rule out a cyanotic heart disease in this child at this point. Okay. All right. Of course, the child are clubbing and other things, it's more obvious. The child is how many? What is the age you mentioned? I didn't get that. Sorry.
3 months, sir. 3 months, sir.
Yeah, 3 months. Yeah. So too early to develop any other feature and too early to have even a cyanotic spell sometimes. Okay. Yeah. So cyanotic heart disease increased pulmonary blood flow and acyanotic heart disease with large shunt, they present very similarly, except for the fact that they, unless you do a SpO2, you may not pick up clinically. Okay. That's about it. Other things I
Yes.
agree. So this pulmonary hypertension is there because you have signs of loud P2 and all that. Cardiac failure. So
Yes,
why is
sir.
the child in cardiac failure?
Sir, because the child has dyspnea and liver which is palpable.
Liver is normally palpable, no, in this age group. 2 centimeters can be normal. So how do you diagnose cardiac failure in this age group? In this child, no. Also, I agree.
Yes.
Tachypnea, increased respiratory distress, but you also said that child had some cold and some wheeze and all that, and you're suspecting respiratory infection also, correct?
Yes,
Yeah.
sir.
So how will you suppose? Indirectly, my question is, how will you diagnose cardiac failure in this patient? In this patient, how do you make sure what are the features? See, this wheeze and tachypnea we cannot use because that could be because of the bronchiolitis or viral infection or respiratory infection. No. Yeah.
Pulmonary edema, sir.
That's quite late, no? Like repetitions.
Yeah.
The child had repetitions now when you examine? No.
No, sir.
Correct.
No, sir.
Yeah. Right. So that's why you're saying cardiac failure. Okay. So rather than liver palpable, you should do the liver span. Okay. The enlarged liver is a sign of cardiac failure in infants. So not only a child with respiratory distress bronchiolitis, liver could be pushed down. So just palpating a 3 centimeter liver does not mean child is in cardiac failure. Okay. You should check the liver
Yes.
span. And infants anything more than 6 or 7 centimeters, child may be in cardiac failure. Plus, of course, other features
Yeah.
could be there. Child may have decreased urine output or all that kind of thing. Okay. All right. And of course,
Yes.
crepitations. All right. And X-ray may show a cardiomegaly. Okay. All right. And congested lungs. Okay. Fine. Why are you saying associated bronchiolitis?
Sir, the child had a history of thick nasal discharge along with cough. The cough could either be due to cardiac pathology or the respiratory pathology, which she also had nasal discharge.
Fine. Okay. So bronchiolitis because of the wheeze and presentation and acute worsening of respiratory symptoms.
Yeah.
All right. So
yes.
Okay. Fine. Yeah. Ravi, anything you want to add?
Yeah. So
You want to ask?
Dr. Narayan said the history of success, rest cycle, and poor sweating are all clues. Failure to thrive is another clue in the beginning that it is not just a viral to begin with. And then the clinical examination. And only thing is, fever and is something which can be tricky if you without that. And wheeze in a CCF, congestive cardiac failure,
Yes, sir.
can be there in the early stages. So putting it as bronchiolitis is difficult in these kids until you have some swab reports. Even then, I would not be easily taking it up because the child has very good setting for a proper left heart failure features. So that will be the way to go about it.
Yes, sir.
Okay. So this is initially the case will be differentiated that is cardiac failure or it's just a PSD with infection. Sometimes clinically it's very difficult to differentiate. The useful pointers are what we have already mentioned. So there is a hepatomegaly by percussion, span is increased, and that absence of fever, okay, and bilateral basal crepes, all that will indicate that child has got a more of a failure rather than infection. So about these things are absent, and fever is the liver is normal size, and and child has got this work of breathing, hyperinflated chest, all that is there. Of course, we look more towards the bronchiolitis. Okay, fine. Yeah, we can proceed.
Only one question. Do you think it's congestive cardiac failure or cardiogenic shock? And do you think you need to differentiate the both?
Sir, the child, when she came to the EMT, she had an heart rate of 130 per minute and her BP was also within normal percentile, sir. And her perfusion was also adequate, sir. So this is more of a congestive cardiac failure than cardiogenic shocks.
Yeah, you need to differentiate these two because that takes the direction of treatment.
Yes, sir. Coming to the workup at admission. Yes. Coming to the workup at admission, the gases done showed compensated respiratory acidosis with a pH of 7.37 and PCO2 69, bicarbs 39.9. CPC and infective markers were negative. RFT and LFT done was normal. Chest X-ray done showed cardiomegaly with the presence of increased pulmonary vascular markings. Echo done showed a perimembranous VST with 7 to 8 mm with bidirectional shunt, and multiple ostium secundum ASD with left to right shunt was also seen. There were also features of severe PAH, and the child had good biventricular function. This is the chest X-ray of the child showing cardiomegaly and increased vascular markings on both the sides. The clinical course at the hospital, we started her on HFNC for the respiratory distress, and she was started on IV antibiotics empirically along with nebulizations, and diuretics, digoxin and enalapril were also started along with other supportive measures. On day 14 of hospitalization, she developed type 2 respiratory failure and she was intubated. The blood gas done at that time should partially compensate to respiratory acidosis. Because of worsening acidosis, CT was done, which showed a right-sided aortic arch compressing the right main bronchus. On day 20, her counts and infective markers done were high, and the antibiotics were hence escalated. Post 7 days of antibiotics, there was pollen counts and blood culture was derived. She was then taken up for ASD-VSD closure, and during the surgery, there was an intraoperating finding of flowing TDA, and it was also clipped. She was started on inotropic support intraoperatively. On post-op day 1, she was extubated to HFNC and inotropes were weaned off. On post-op day 4, the respiratory distress reoccurred when low-flow oxygen was initiated. Her blood gas showed compensatory respiratory acidosis, and she was reintubated in view of repeated desaturations. Chest X-ray done showed no new infiltrates. CBC and infective markers were negative. However, there was persistent wheeze. A diagnostic bronchoscopy was done, which showed 50% compression of right main bronchus by the right aortic arch. So the pulmonologist advised to continue positive pressure support. On post-op day 10, there were low-grade fever spikes along with episodes of desaturation. And when the chest X-ray was repeated, there were new infiltrates. And CTPA was also done because of persistent wheeze to look for vascular rings, but there were no Schimser rings. Because of the fever, respiratory and blood culture was done, and the respiratory secretions grew Acinetobacter baumannii, which was treated with meropenem. Now, the child has been extubated and is on low-flow oxygen. And that is the end of the presentation, sir.
Okay, so that was well managed, a good presentation. A few questions, no? When you started the patient, when this patient comes, so what was their initial diagnosis? Was the cardiac failure, looks like, correct?
Yes,
sir. It's more like cardiac failure,
yes.
What he came with. So
Yes,
your
sir.
respiratory panel, everything was negative. X-ray, everything looks more like it. So, in this child, in a cardiac failure, what is the role of acute cardiac failure like this, which is with a large left-right shunt? Okay, with a
Yes.
usually, what is the indication for giving digoxin? What is the role of digoxin?
Sir, if there is a low cardiac output, if the population is not adequate.
So in this child, what is the cause of cardiac failure? It is volume overload of the ventricle, correct? Whenever there is a
Yes,
left to
sir.
right shunt, there is a volume overload of the left ventricle. So left ventricle is our volume overload. So main problem of cause of cardiac failure is the volume overload. So diuretics is the mainstay of therapy when this patient has a cardiac failure. And sometimes if the lungs are congested, you can give positive pressure, what we are given. Okay. Contractility is not
Yes,
an issue.
sir.
Even your echo showed that contractility is normal, correct? Yeah.
Yes, sir.
So digoxin usually has not much role in this kind of patients. And so digoxin also is a little bit dangerous drug to use. No, it's got a narrow therapeutic index. Okay, maybe useful
Yes,
in a
sir.
patient who has got muscle disease like cardiomyopathy chronically. You may have a role, but
Yes, sir.
acutely, both acute volume overload conditions or pressure overload conditions, where the cardiac muscle is normal, digoxin may not have much role. Okay.
Yeah.
Because we also used to give this in the past, but nowadays we are stopped using it. Okay, all right, good.
Yeah. Yes, sir.
Then
Yes, sir.
yeah, so that is of my comment is that okay, so this child at admission, one of the important priorities for us is to make sure that the cardiac failure is treated. The basic cause of cardiac failure is the volume overload. So diuretics will be the mainstay. Then respiratory distress, we need respiratory support, and positive pressure ventilation will help because it will relieve the lung congestion, and also positive pressure also can help the cardiac contractility to a certain extent. It can decrease the afterload and all that. Okay, yeah, that we'll not go into that discussion. So that is the basic treatment the child needs at admission. And you should also in patients like this, children like this who also got a large blood flow, you should also be careful giving too much oxygen to them. Okay, that's also another thing. Too much oxygen should be avoided because if you give a lot of oxygen, the pulmonary blood flow can get worse, and then the failure can get worse. Okay, because the oxygen is a vasodilator. So in this, with a large shunt, if you give a lot of oxygen to them, so they can actually the pulmonary vessels can dilate, pulmonary pressure can, pulmonary oxygen can come down, and the left pressure can actually get worse. Okay. So we should use judiciously oxygen, the titrated way to maintain the SpO2 between say close to 93 to 95. Okay, we don't need a 100% SpO2 in this time. So oxygen also should be a bit carefully used. These are the important things in the emergency which can help in stabilizing the child. And of course, you give antibiotics to the child is ruled out. Okay. Another question I want to ask is, how do you decide to intubate this child? Suppose this child. When did you decide to intubate this child? You said you intubate the child on day 14, no? So how did you decide to intubate this child?
Sir, in order to reduce the workload on the heart, it's better to intubate this child when there is severe respiratory distress or an impending respiratory failure.
Good. So I want to recognize that the children, most children like this, we intubate them based only on their clinical status, not based on ABG. Okay. ABG of course is useful, but because ABG may show even such an admission, ABG was showing 60 or something with PCO2. Yes or no?
Yes, sir.
Yes, sir. But the decision to intubate is always based on the clinical status of the patient. Okay.
Yes, sir.
It's always a clinical decision. You feel the patient tearing out, patient sensorium is going down, then of course you intubate. I think the patient won't be able to maintain the airway, or it may tear down. Right? Yeah. All right.
Yes, sir. Yes.
Yeah. Then one more question. What is the common complication, immediate post-op? Since you manage the patient immediate post-op also, no? You take up such patient with large left-right shunt for surgery, what is the immediate post-op complication which you're worried about, which can actually be very life-threatening? I think you didn't have in this patient, but this patient had the setting.
Sorry, sir, I did not get the question, sir.
Yeah, I'll repeat that. What is the immediate life-threatening complication this child can develop in the day 1, day 2 of after surgery? This infant, which we should be very careful about, and we should be cautious. This child didn't have a complication, but what is the common complication they can develop? A child like this. Okay, I'll tell you. Okay, this child has got a large left-right shunt with a hyperdynamic pulmonary hypertension. So no. So post-op, this child has very high risk for PAH crisis. They can go into acute crisis in PAH post-op. Okay. So first 24 hours, 48 hours, you should be very careful with this children. Okay. You should be able to recognize an acute PAH crisis. That is like something like, as bad as an ICP. It can actually be very bad to manage. Very difficult to manage sometimes. Okay. All right.
Yes.
Okay. But this child didn't have that problem. Okay. All right.
Yes. Yes.
Yeah. Fine. Ravi, anything else you want to add?
Okay, Narayanan, you have extensively covered. I don't want to put. I'm very afraid at times to junior doctor. But I think you covered mostly.
Yeah. Okay. I think we'll proceed. Anyway, it was a nice presentation. I just want to tell you a few things which, important points when you manage this patient. That's what we are. To summarize, I'll tell you. So summarize what we discussed in this case is that a case comes like this, the large shunt, don't always assume that it's all acyanotic if there's no history of cyanosis. Sometimes cyanotic heart is increased, especially small infants, less than 2 months, 3 months, no? Because it can still be a cyanotic heart with increased permanent blood flow. Okay. It will be complex cyanotic heart disease. Second thing is, your immediate management is to differentiate the infection and failure. Both are slightly different management. And like what Dr. Ravi has already mentioned, cardiogenic shock also you should be able to recognize. Cardiogenic shock is a continuum of if the cardiac failure can get worse, you can finally go into cardiogenic shock where you get signs of poor perfusion. Okay. Yeah, then the management is different. Okay. We need to be more aggressive. So then immediate management is of course diuretic in this cell because volume overload is the problem. So you give diuretics, maybe a little bit of positive pressure, then take for limited oxygen. Oxygen should not be liberally give oxygen to this children. Sometimes it can worsen the failure. Okay.
Yes.
And of course, pH crisis. You should know what is pH can sometimes go into crisis. That you should be aware that such things can happen.
Yes.
All right. Okay. Good. Thank you. Thank you.
Thank you.
Armugam?
Sir, can I start my presentation, sir?
Yeah, you start.
Yeah, please.
Am I audible?
Yes, yes.
Am I audible, sir?
You are.
Yeah, you are. Yeah, you are.
Yes, sir. Hello, sir. Slides are visible?
No.
Yeah.
Yeah. Let's see. You can see that.
Yes, sir.
Start.
Yes. 13 years old female child brought by her parents with complaints of difficulty in breathing for past 3 months, which was more on last 2 days, which was restricting his daily routine activities. An history of altered sensorium and lethargy since today's afternoon. An history of reduced urine output for last 1 week. Child was a known case of chronic kidney disease stage 5. Child was having Wilms tumor left kidney, which was operated and also on chemotherapy and radiotherapy since 3 years of age. Past history. Diagnosis of left kidney Wilms tumors was made at 3 years of age. Radical nephrectomy was done at 4 years of age and child was on follow-up radio and chemotherapy. Child was born of non-consanguineous marriage, firstborn of non-consanguineous marriage. No history of similar illness among family members. Developmentally normal child. Anthropometry showed malnourishment and with short stature. At EMD, initial assessment. Child was comatose. Work of breathing. The child was on mechanical ventilation, controlled ventilation. Circulation. Child was looking pale. Impression. The child is sick. Primary assessment. Airway, intubated outside itself. Breathing, child was on mechanical ventilation volume control mode, which respiratory rate of 30 per minute, tidal volume 300 ml, 10 ml per kg. PEEP is 5. FiO2 requirement is 40% for maintaining saturation. Circulation is hot rate is around 100 per minute. Pulse volume was good. CFT less than 3 seconds. Pallor present. BP is around 100 or 70 millimeter mercury, which was within centiles. Child is anuria for past 12 hours. Disability, GCS was very much poor. E1, VT, M1. Bilateral pupils equally reacting to light. GRBS, child is euglycemic. Exposure temperature is normal. Secondary assessment. Signs and symptoms showed breathlessness and tachypnea. No allergic history. Medications, currently child is on native medications. Past medical history, child was diagnosed to have Wilms tumor of left kidney, which was operated at 4 years of age, and child was on follow-up radiotherapy and chemotherapy. Last meal was taken at 12 hours back. Even child was intubated in nearby hospital because of poor GCS and referred to higher center. Focused physical examination showed perabdomen was soft, no organomegaly, and no mass palpable. CVS S1 S2 plus, no murmur. RS normal vesicular bed sound plus. CNS GCS E1 VT VM1. Bilateral pupil equally reacting to lead. Child was on fentanyl infusion. Sir? Hello?
Yeah, start.
Sir, can we continue with the diagnostic evaluation, sir? Assessment?
Hello?
Sir, is it audible, sir?
Yes.
Yeah, you're audible. You're audible. Ravi, you
sir,
want to
I
ask anything or we'll proceed?
Can you think what is your provisional diagnosis at this point of time before going into the labs?
Sir, child has a known history of Wilms tumor operated, sir, and CKD of stage 5, sir. So maybe the child will have chronic kidney disease, renal failure, stage 5 chronic kidney disease, renal failure. Maybe the presentation will be uremic encephalopathy, sir.
Okay. So, yeah. So, can I reframe what you have said, Dr. So, I would say the child is having acute renal injury or acute renal failure on a background of a CKD, which may be to the Wilson. So, your biggest problem now is having an acute renal failure or AKI, acute kidney injury, which is the latest way of calling it.
Okay, sir.
Yeah. So, because that's your major concern. No.
Yes, sir. Yes, sir.
Okay. So, what are other reasons for this child getting intubated? One is, of course, agree. Anything else? Uremic encephalopathy. What else can lead to a child with chronic kidney disease with an acute decompensation, including intubation? Other than encephalopathy, anything else?
Sir, chronic anemia with failure, sir.
Okay, so child could be having pulmonary edema. Oliguria is there.
Oliguria is pulmonary
edema. Okay, anything else? So it could be having any electrolyte imbalances or no?
Electrolytes imbalance, sir. Hyperkalemia, hypocalcemia.
Okay, all that is possible. All this can produce seizures. They can affect the cardiac muscle. If sodium is low, means they can produce encephalopathy. So many possibilities are there in this child. One thing I like to know, usually this children, BP should be on the higher side. No, you said BP is only 100/70. So why BP is why there's no hypertension?
170, sir. It's what's recordable. Maybe the child may be in shock, sir. Yes, sir. Yes, during presentation. But pulse value is good during the presentation.
Yeah. But that is an important point here. A child who is chronically hypertensive. Okay.
Yes, sir.
So in that child, you need not be hypertensive by standard definition to call it hypertension. Okay. So if there is 25% fall from, suppose this child's normal blood pressure was 150 systolic and by or 140 and 100 and all that, 80, 90, then this BP means child is actually BP has fallen by more than 25-30%. So from the baseline.
Yes,
so
sir.
that this could be so this could be a worrying sign. Or a child who's coming like this, who's you're getting 100/70 blood pressure is not normal. It could be hypertension for this child because this child is used to a higher.
Yes, sir. Yes, sir.
So this child is actually
higher blood pressure,
sick.
Yes, sir.
This child is having multiple problems. Okay, not only it could be hemodynamic unstable also. Okay.
Yes, sir. Yes, sir.
But sodium does not always mean that child is not in having a hemodynamic compromise. Okay, BP could be worrying for us because we expect hypertension in this child.
Hypertension, sir. Yes, sir.
Yeah, fine. So that could be a problem. Yeah, fine. Proceed.
Sir, a diagnostic assessment done at EMD, ABG showed severe metabolic acidosis with respiratory alkalosis. pH was 6.9, PCO2 showed 11.9, bicarb was only 1.6, lactate is 5, electrolytes, sodium is 140 and potassium is 5.
I can't hear you.
And ionized calcium was only 5 manion gap metal. Urea is 6.97. HB is 2 gram per deciliter. We have done the bedside ultrasound and echo. IVC showed 12 mm volume of IVC and bilateral minimal tool effusion with pericardial effusion. But LV contractility is borderline.
Hello.
Yes, sir.
Yeah.
Yes, sir. Yes, sir.
Yeah. So, what are the abnormalities you found here?
So severe metabolic acidosis, sir.
Okay. So
Bicarbonate
that can be.
is
Yeah. So
only
ideally,
1.6 and pH is very much low.
yeah. So this ideally you should calculate the anion gap to just make sure that it is an increased anion gap. But in this child, the whole setting is for uremic, uremia and acidosis. So this most probably because of accumulation of organic acids because of uremia.
Yes.
Okay, fine. But child also, as we expected, no, child also got a hemodynamic compromise. That's why lactate is fine.
Lactate is fine,
Okay.
sir.
Yeah. So that BP and all is low. That's why. The perfusion problem is there, possibly.
Yes,
Okay. And how much the potassium you said? 5, I can see it here.
5.6, sir. I haven't
5.6.
mentioned in this slide, but 5.6 at
Yeah.
presentation.
Okay. Anion gap is also prolonged.
Yes, sir.
Yeah, that says that there is a accumulation of some acid. If anion gap is normal, the child is metabolic acidosis, the mechanism is bicarb loss. Okay, so here it is. Anion gap is high, means
urea.
Some acid has accumulated.
Acid accumulation, sir.
Uremic organic acids. NS calcium is also low. Okay. Yeah. So what did you do for this day? What are the priorities? You say, no, hemoglobin is only 2 grams per deciliter.
Yes, sir. Yes, sir.
Okay. All right. So what will you do now with this? What will be your first
management?
priority?
Initially, we have to stabilize the airway and breathing to control the mechanical ventilation. Circulation, sir, we have started on bicarbonate infusion, sir, because IVC volume is 13 mm. It's much adequate. So in this case, we have to give bolus or rush to fluids, or we can start on only maintenance bicarbonate infusion is enough, sir.
Ravi, you want to answer or shall I? Ravi?
So I will take it up from you. So here the bicarb is low and pH is very low. You can calculate the base deficit, calculate the correction. 1/2 of it you can give quickly, and remaining you can take it over maybe over 8 hours and then divide. But you need to bring the pH up, because that's very important, and see whether there's a response, because definitely your HP is also low. So calculate the bicarb requirement, give it 1/2 in the first 8 hours, and try to see whether there is a response quickly.
Okay, sir. Sir, we have given the bicarbonate infusion, and because of
actually, another point I would like to add, IVC, the absolute diameter is actually, IVC, you should ideally see the variability. Okay. Anyway, so in this child, the first priority is this child is not in pulmonary edema, right?
Yes, sir, not in pulmonary edema, sir.
Yeah, and BP is also low. So this child,
BP is on the lower side, sir.
Yeah, correct. And so what can immediately kill this child is the perfusion problem, as well as the electrolyte imbalances. So you should concentrate your efforts on that. Okay. So what I'll be most concerned in this child will be the fact that his IHB is only 2 and his lactate is high and all that. Correct. So he's got a perfusion and oxygen delivery problem that has to be addressed first. Okay.
Yes,
so this patient, if you can get you can easily give some fluid for this patient, especially if you can get some pack solution, give it, because 2 grams is too low for any child.
Yes, sir.
How much?
Ideally, 2 grams is the HP. So start with some 5 ml per kilo of blood, but ideally, because this cell potassium is already 5.6. So when you give blood transfusion, potassium can spike and we can have a cardiac arrest. So ideally, blood given only after you establish urine output, or you put him on some kind of RRT, so to be on the safer side. Okay. But otherwise, that's ideal. But anyway, you can medically manage hyperkalemia also. So if you're giving blood to this patient, you should be carefully monitoring the potassium, and you should give start giving some insulin dextrose or bicarb to compensate for the expected rise in potassium. And NS calcium must be corrected immediately. That could be one of the reasons why the contractility is poor. Okay.
Yes, sir.
NS calcium is very, very low. Okay. So this patient will give, you need some filling, preferably blood, because the HP is only 2. NS calcium must be corrected. Potassium is 5 point something. So you should look for active signs of any ECG changes. Okay. So these are the priorities in this child, and only way we can improve is acidosis. The mechanism of acidosis here is accumulation of acids, yes or no? So the best way to correct the acidosis, the acid is to either take it out through the kidney if it's possible, if it's passing urine. But in this case, very unlikely, because this stage 5, almost ESRD. So his global filtration is very low. GFR is very low, so it's difficult to get anything out of the kidney. So ideally, the best way of improving his thing is he needs an urgent renal replacement therapy depending on your what is available to you immediately. Okay, it could be hemodialysis, it could be CRRT, it could be peritoneal dialysis, whatever it is. That's what is urgent. In this patient, the first few hours we have to start RRT. Otherwise, we may not. That can correct everything. They can remove the acids and it can. So that's the priority here. Okay.
Yes, sir. Yes, sir.
Yeah, fine. Bicarbonate infusion, of course, we can give, but be careful. I mean, this patient like this, if you give suddenly give bicarb, no? Many, like for example, the calcium can get affected, and something else also can happen. So be careful.
Yes, sir.
Don't
Yes,
give
we have started on also calcium correction
yeah,
also, sir.
Yeah. Too much bolus bicarb should not be given. Like what Ravi told, calculate and give half of it maybe initially, and that is to die. And then that's not the answer. Bicarb is just buying time here, because unless you remove the acids, by a dialysis or something, this acidose is not going to get improved. It will come back. Okay.
Yes, sir. Sir, during the course of the illness, child have developed cardiac arrest, sir. So hypotensive shock decompensated. We have started on inotropes, noradrenaline, and dopamine. Not able to proceed with hemodialysis, sir. So in case of we can another plan is we have to continue renal replacement therapy. We have to start, but the child has expired finally, sir.
Yeah, exposed is very bad.
Within 12 hours, child have expired, reaching the hospital, sir.
Yeah, very difficult case. Yeah. So, I mean,
this case, with all these bicarb and things, you want to do dialysis. Which modality you want to do? And
sir, in cases of uremic encephalopathy, we have to do the continuous renal replacement therapy is better than the hemodialysis, acute filtration, sir.
Why?
Because rapid regular filtration of urea and other acids can be more beneficial in case of we can't reduce the urea and creatinine in the blood. We can produce osmolar gap in this blood cell.
So yeah, so rapid shifts can cause a disequilibrium syndrome or osmolar rapid changes can cause disequilibrium syndrome. That is one thing. So hemodialysis may not be good, and in a patient who is having a lowish BP, who is very unstable, the hemodynamics will rapidly drop with the hemodialysis. So CRRT is another option which you can think. And then when it comes to CRRT versus because people will again ask, do you have CRRT or not? And then if you are not able to do CRRT and hemodialysis is not possible, is there any other methods you can use?
Sir, peritoneal dialysis is another option, sir, but it needs a lot of time to clear. It takes a lot of time.
Peritoneal dialysis is not very effective. That I agree.
Yes, sir. In this
scenario where when you don't have anything, it can be still tried until you get a way out. Okay, is there any other modality
SLED option, sir, sustained low efficiency dialysis.
Yeah, so that is also a possibility, because in economic scenarios, that is also a possibility. It is neither a CRRT nor a dialysis, somewhere in between, and it is cost effective and can be done in a sustained way. A lot of us do SLED to avoid the cost and the challenges of CRRT. Okay, because to do a hemodialysis is not in this case for sure.
Okay, sir. Okay, sir.
Yeah, I agree with what Ravi has said. The mode of don't go with the impression that one mode is vastly superior to other modes. It's basically based on the patient status. Okay, so if this patient hemodynamics was stable, we can still do hemodialysis. Okay, what we do is children is suppose they have a stable hemodynamics, we can easily do HD also. It's not that it always produces a disequilibration. Okay, so first dialysis we do only 1 hour. Short duration dialysis we can do. With some ultrafiltration if needed. In this patient, of course, it doesn't need. So that did not produce a disequilibration. Okay, then we can repeat the hemodialysis after say 12 to 24 hours later. Second cycle can be done. If his hemodynamic unstable, of course, this is not a good candidate. This patient is not a good candidate for HD. Most probably he will collapse. So either we should do SLED or one of the sustained, slow flows in dialysis or a CRRT. But CRRT is difficult. It's very costly. Access is limited. So PD will work. It's a misnomer that PD doesn't work. And many of you think that it is not effective. In fact, we do much more PD than any other thing in our hospital, even though we have access to everything. PD in children it works quite well, especially smaller children. It clears at least whatever you want to correct. The acidosis and other things will get cleared within 12 hours. Even CRRT will take that much time because CRRT is a slow process. Okay. If you do CRRT, that will take around 24 hours to collect everything because it is a slow process. PD also can work similarly. It may not be as good as CRRT, but it's better than nothing else, and easily can be done in any place with the bedside. You don't need any ICU equipment, you just need a tube. Yeah. It's a very
sir. Thank
viable option even in this patient. If you don't have access to anything else, should try. Especially if your rapid cycles, if you do all the potassium and all get rapidly washed out.
Okay, sir.
I agree with Dr. Narayan. So there is no one inferior or one superior. It is availability of resources, expert access, everything takes into. And I think you said about the hemodialysis of 1 hour, and we don't do a counter current. We do a counter current is going the blood in one direction and the dialysis in the opposite direction. When you do the first cycle, we do it in the same direction so that you don't rapidly pull anything. And to avoid, I think fairly the take-home message will be definitely to be open for the all kind of modalities. There is no superior modality, and to stabilize electrolyte imbalance at the beginning. That's the most killing thing at that point of time in this child. Stabilize the electrolytes. That's very important thing. And all the modalities has one advantage and disadvantage. Choose wisely.
Okay, sir. Sir, can I move on to next system, sir?
Yeah, please.
Respiratory system. Case history: 5-year-old male child came with the complaints of cough and cold for 4 days, productive cough, complaints of fever for 3 days, high-grade fever, which was reduced by taking paracetamol, complaints of fast breathing for past 1 day, no history of previous hospitalization. Child is a known case of Wheezer, not on any controller therapy. Developmentally normal child. Child has immunized up to 1.5 years as per NIS program. Anthropometry was normal. No history of contact with TB, tuberculosis. No history of allergy. At EMD, initial assessment show appearance normal, tone, interactive, look, speech is normal. Work of breathing, child had retractions, nasal flaring present. Increased work of breathing is there. Circulation was normal. Primary assessment, child's airway is clear and maintainable. Breathing, child was breathing at the rate of 48 per minute. Intercostal retractions, subcostal retractions, and suprasternal retractions and flaring was present. Bilateral creps are there. Child is maintaining saturation is room air 94%. Circulation, child is having heart rate of 138, tachycardia. Pulse volume was good. CFT less than 3 seconds. BP is 100/70. Urine output was adequate. GCS, full GCS 15/15. Bilateral pupil equally reacting to light. Sugars normal. Temperature, child has hyperthermia 102 degree Fahrenheit. Secondary assessment, signs and symptoms. Child was having breathlessness and tachypnea. No allergy. No, child is not on any medication. Post medical history, child is a known Wheezer, not on any treatment. Child had need 3 hours back. Even insidious onset of breathlessness. This is the 4th day of illness. Child has developed breathlessness for 1 day. Focus physical assessment show RS bilateral air present. Bilateral creps are there. CVS S1 S2 pleasant, no murmur. Per abdomen soft. CNS no focal neurological deficit. So we have done the chest X-ray EMD itself, which shows bilateral perihilar infiltrates.
I think you can discuss from the clinical history. What are the?
Yes, sir. I can wait, sir.
Yeah. So, So from the clinical evaluation at the end of history and examination, what was the diagnosis you considered?
Sir, probably pneumonia, sir.
Okay, why you're saying so?
I can offer a differential diagnosis, sir. Pneumonia.
Okay, so pneumonia means why you're saying pneumonia?
Sir, child has high-grade fever and associated with cough and productive cough. That's currently child is in respiratory distress.
Yeah, fine. So a child comes with respiratory fever and respiratory distress plus possibly pneumonia. I agree. But this child also could have past history of wheezing, no?
Wheezer, sir. Yes, sir.
So what are the other possibilities?
Yes, sir. Can be the acute exacerbation of wheeze also, but on auscultation, predominantly creps are predominant than wheezing.
Okay, so fine.
High-grade fever, 4 days of high-grade fever.
Acute exacerbation because you don't have any. So you don't have any signs of wheeze, like airway involvement.
Yes, sir. Lower
so
airway.
Okay, so all right. But the child's age you mentioned 4 years, no?
4 years, sir. 4 years old child.
4 years. Okay, fine. Yeah. You can proceed. Ravi, anything else you want to ask?
I think fairly good, and I think I appreciate you. You have gone for the physiological diagnosis first, saying it's a respiratory distress, severity as respiratory distress, physiological as a most probable lower parenchymal, and then putting in pneumonia as a possibility, because that gives you are able to identify the severity, you are able to identify where the pathology is, and then a probable diagnosis. And in intensives, we go only by that. We don't want a diagnosis. We want the system of involvement. We want the severity, and then only we look for a diagnosis.
Okay, sir.
Good.
So total count was normal, which was neutrophilic predominant. So we have initially started on oxygen support by face marks 4 liter per minute, and we have started on antibiotics, ceftriaxone, and other supportive medications. The regular monitoring of pediatric respiratory severity score assessment as per respiratory rate, wheeze, work of breathing, and saturation feeding difficulties were assessed. Course in the hospital, child required ICU care in view of respiratory distress, then going to respiratory failure, child had desaturation. So started on HFNC support, high flow oxygen support. But child has response well, ceftriaxone therapy, and discharge after 4 days with oral antibiotics.
Okay, so this child is fairly simple in a way, and we will look in slightly away from the ICU and look from the general pediatric aspects. You started on ceftriaxone. Do you feel any other investigations? Did you take blood culture? Did you do?
Yes, sir. We have sent the blood culture, sir, which was sterile.
Can you go back to the previous slide on the labs?
Yes, sir.
Labs. Okay. So blood culture you have sent.
Sir, we have done the chest X-ray EMB itself, sir, which showed bilateral infiltrates. There is no lobar consolidation as such, sir.
Okay, so you have ruled out lobar consolidation.
CBC was 1,000. Yes, sir. We have done creatinine in case of we have had a vancomycin in case.
No, let us go one by one. And did you think about any
So
other
respiratory
secretions being sent for something? And do you think
the respiratory panel can be sent, sir, but child has responded well within 2 days of ceftriaxone, sir. So we have sent the respiratory panel for this child.
What's the advantage of doing a respiratory panel?
Sir, it is a PCR method, sir. Chain reactions, we can get the report within 3 to 4 hours, sir. Sometimes with the sensitivity of drugs also, we can get to this report, sir, by using the panel.
So what is the biggest advantage of it?
Sir, we can detect the early detection of the organism and prevent the further complications. Sir.
Okay. So this all brings to the next question. You made a diagnosis of a respiratory lower airway, lower parenchymal problem. You made it a severity, and then you said probable pneumonia. Looking at the X-ray or looking at the age, what are the possible organisms you want to treat?
Sir, as per the age, bacterial and viral organisms are most common. Sir, bacterial streptococcal pneumonia, the most common. Second one is H.
Okay. And among the bacteria, you have put
on viral influenza virus.
Yes. So if it's not a lobar pneumonia, okay, it's not a lobar pneumonia. You have very clearly said. So at this age, do you think about atypical organism? What is the organism which you look about? And
sir, mycoplasma can be present. Mycoplasma.
Yes. So how do you differentiate an atypical pneumonia from a pneumonia?
Sir, according to the presentation and chest X-ray features and responding well to antibiotics, we have started empirical antibiotics.
Okay. And what will be the X-ray changes in atypical pneumonia?
Sir, only bilateral infiltrates will be there. There will be no lobar consolidation.
Okay. And clinical
diffuse infiltrates.
In clinical features?
Child is not so much sick like bacterial pneumonia. The child is able to walk and do daily, but still the child have persistent fever spikes and coughing.
So yeah, so
not responding well to
is not lobar and not very sick to an extent. It's not always dictum, but and then you may have extra respiratory symptoms. These are all other clues which you may have from the bad thing. And
Okay,
again,
sir.
viral. So see, had you had a lobar, then you could have easily put in as a most probable bacterial and all.
Bacterial, yes, sir.
But now you didn't have a lobar infiltrate and antibiotic response. Maybe a viral. Who knows?
Maybe,
It could be
sir.
a viral
Yes, sir.
which
Yes,
doesn't
sir.
mean
Viral
anything.
also. Yes, sir.
And when you treat empirical, what all antibiotics you would have thought in this child, because the child needs HFNC, ICU. Do you think ceftriaxone alone is sufficient?
Sir, maybe can we add vancomycin also for that child, sir?
Why do you want to add vancomycin?
Sir, to rule out staph aureus coverage, sir.
So
MRSA.
you wanted to cover staph aureus. Okay, fine. Then
Sir, mostly for staph aureus and prevent further complications, MRSA complications. We are adding vancomycin.
yeah. So you need to remember we talked about atypical with bilateral infiltrates. You should think about that also, and not sick looking except for a respiratory distress. And then,
Yes, sir.
do you think you will add oseltamivir thinking it because you're not doing a viral
PCR,
panel?
we have not done the PCR, sir. We have not done.
These will be your initial until you get some clue, and then you will de-escalate. Especially, this child is not requiring oxygen. This child doesn't need HFNC. I don't mind anything, but when you need all these things, you need to slightly go up and then come back. Always in the
Okay.
ICU, we always go up straight.
Okay,
And
sir. Okay, sir.
then we descend down. We don't climb. We descend.
Okay, sir.
Okay. And that will be the way in the antibiotics, and then coming down slowly as you rule out one by one. Okay. And
Okay, sir.
for example, as you thought processed as this child having bacterial infections, it is going to be a strep pneumonia. And you have started antibiotic, you said after 4th day the fever settled. If the fever is not settling, what will be?
Sir, we can repeat the X-ray, sir, to rule out any further complications, any further.
What are the further complications you are looking
at? Sir, empyema or any lobar consolidation, any collapse of the lung due to secretions. We can rule out any further, look for any further worsening, sir. Repeating the X-ray. Any empyema or pleural effusions can take place during that time.
If you have a pleural effusion by X-ray, will you be able to define whether it's empyema or just a pneumonic effusion?
Sir, ultrasound has more specific marker than X-ray, sir, because we can rule out by doing bedside ultrasound, we can detect intra-echoic changes.
Okay.
X-ray maybe thickened margin can be considered as.
Okay. X-ray is very difficult to differentiate both.
Differentiate, sir. Very difficult to differentiate.
And
we can
in ultrasound, whatever you say, in a late, thickened, unorganized empyema will show all these things. Turbid, or you have a fibrin strand. Even a normal effusion over time can have fibrin strand. So always don't think a fibrin strand is always an empyema.
Okay, sir.
Long-standing effusion can also say. So then what will you do?
Sir, after effusion, or we can further upgrade the antibiotics.
If you think there is a empyema, escalating the antibiotics.
Sir, yes, sir. Empyema, we can proceed with the. No, we can do the therapeutic effusion, tapping, sir, or we can proceed with the. In case severe empyema, we can proceed with ICD, sir, intercostal drainage.
Okay. If you think it is empyema versus pneumonic effusion, you want to do tapping. If you want to do tapping, what will you do? Investigate. How will you know it's a empyema or a effusion? Just a pneumonic effusion. Sir, and I'm going towards not much into the ICU, but I'm just pulling in the other direction and coming because complications are to be looked at.
Sir, we can do the biochemical analysis. We can rule out exudate or transudate. We exudate predominantly. We can do the gram staining also. We can done.
Yeah. So gram staining has a role, pH has a role, and culture only has a role.
Otherwise,
all other exudate transudate concepts are moving out. Okay.
Okay, sir.
And then if the fever persists, you may try to put ICD drain.
ICD tubes.
Okay. And if it looks like an exudate, pus is coming, what will you do?
Sir, we can continue the drainage, sir, and further increase the
drainage. Still the child is
still the side is better, looking better, and
if it's not improving, child is having still fever, and I'm just checking towards the ICU aspect.
Sir, can we proceed with bronchoscopy for this stage to look for any collapse of particular affected lung?
Okay, so no, there is no collapse, but there is a effusion still there. And people say there is thick fibrin stand, we are now, and empyema. What do you want to do?
Sir, we can give the urokinase like thing and the fibrinolytic agents on the pleural cavity. We can collapse.
Yeah, so you want to release the fibrins, urokinase, and what else can you do?
Streptokinase and
Okay, so these are all chemical ways. Is
yes,
there
sir.
any
We
other
can
way?
use the
We can do something called VATS also. These are two possibilities, and I will not go in detail which is better, which is not, which is good to do start early, because still
okay,
there's a
sir.
lot of debate. And yes, as you said, if it is empyema and you think it is fibrin, it's not draining well, you have to consider either chemically removing or by putting a VATS. VATS video assisted thoracosynthesis.
Thoracosynthesis like yes, sir.
Okay, and we will go. I think here I'll stop. Dr. Narayan, if you feel anything more.
I think most of the things you have covered. Yeah. So, what I want to like to add is, so anything about the respiratory support which you offered for this children. So, how do you escalate respiratory support any child coming with respiratory distress? Suppose a pneumonia child comes to you, how do you decide to escalate support?
Sir, in this
And
case,
what
we
are
have
the
used a press scoring system, sir. According to, in case of persistent high press scoring system, we can escalate to HFNC. If persistent distress, high FAO2 equipment can, sir.
So how will you escalate? What is the first thing will you use? What is the next level like that? How do you normally escalate? I'm asking.
Sir, in case low flow oxygen can be escalated into high flow oxygen therapy,
Okay.
sir.
Okay, good. After that?
After that, mechanical intubation, invasive ventilation, non-invasive ventilation, then invasive ventilation, sir.
Yeah, so you can try. So, so in this patient, like what kind of complications? Like one set of complications is what he has mentioned, all the infective complications. Other complications are respiratory failure.
Yes, sir.
So if this child goes into respiratory failure, it could be an evolving ARDS or an acute lung injury. Okay, that you must be knowing in all that. So no, so in a evolving acute lung injury and ARDS, we should intubate the child quite early. Okay, so you can try NIV for some time. If child is not responding, you should decide to intubate them early.
Yes, sir.
Okay,
yes, sir.
so how can you give NIV to this child? Suppose he's not managing on a high flow. How do you give NIV for this child outside the ICU?
By using ventilators, mechanical ventilation, sir.
No. How do you give an NIV to this child? How do you give NIV to this child outside the ICU? Is there any way?
Sir, bag and mask ventilation, sir.
No. Any other way, easy way we can give NIV. NIV means okay. We can try CPAPs, no? Bubble CPAP or CPAP support. It can be BiPAP or if that I mean sometimes you can even try small infants. You can try even a bubble CPAP that indigenous CPAP system can be tried. Okay. Yeah. Okay. Fine. Good. I think that's it from my side. I mean, this is a very simple case, well managed.
Thank you, sir.
Thank you very much, our faculties, Narayan and Dr. Ravi Kumar, and Dr. Muruganandan for preparing your PGs very well. And thanks to Dr. Mridula and Dr. Arumugam for presenting. Yeah. So, any other questions from any of the others, actually, or comments before we close the show? Dr. Murugesh Lakshman, sir, anything else? Balashankar, sir, Sulung, sir.
It's a very good discussion, and I think for all the four emergencies, they have covered what is needed in the acute management of such cases when they come to casualty. Okay, it's been discussed. Thank you very much, both the teachers, Ravi Kumar sir and Narayan sir. And it's a wonderful discussion we had. And we learned a lot, so many things from you today. Thank you, sir. Thank you very much.
Thank you, sir. Thank you very much for this comment, sir. Thank you very much. So we'll call it a day. Good night.
Thanks.
Thank you, sir. Good night.
Thank you all.
Thank you, presenters. Well done.
Thank you, sir.